Hi there, everyone. We're just going to take a minute to make sure everyone is able to get in from the waiting room. Okay, it looks like our numbers started to steady down. My name's Callum Donnelly. I'm a faculty member here with reproductive medicine, and I'm really happy to welcome everyone back to our fall semester for the equine seminar series. That everyone's had a good summer with their horses. Um, just some housekeeping today with our speaker. If you do have a question, we will have the chat function working. So please put your questions, in the Q&A, and then we'll answer them live from the panelists, or questions that we think would be good shared with the group we'll save for our speaker at the end. Our next seminar, if you have your calendars out, will be October 21st, where we'll be joined by our very own Dr. Goodale, who'll be talking to us about some equine welfare topics. Gives me great pleasure, though, today to introduce our speaker, Dr. Barbara Delvescovo. Dr. Delvescovo hails from Italy. She's been here at Cornell since 2017, first as a medicine resident and then as a critical care fellow. She's both a boarded internal medicine and critical care specialist. Barbara recently joined the faculty with the critical care service. She offers emergency critical care to large animals from throughout the New York and Northeast area. She has a specific interest in colic and also critical care of adult horses and neonates. So thanks, Dr. Delvescovo.
All right, thank you so much for the kind introduction and welcome everybody. And so tonight I wanted to bring us a little bit on a journey, a gut journey, to try to understand a little bit more colic in our horses, which is such a common problem that we all see. I specifically see, but I'm sure all of you as well. And so what I wanted to chat about tonight was, first of all, like, what is colic? What do we mean with this term? And then go into deeper, a little bit more about common causes of colics that affect different areas of the GI tract. And then why does your vet would perform what's called a colic workup? So how do we try to narrow down the problems in the different areas of the GI tract, and why we do the things that we do when we try to fix your horse or treat your horse, and then kind of look better into like common procedures and diagnostic that hopefully you never will see performed on your horse, and hopefully you have never seen performed, but in case that happens to you, you know exactly what we do and why. And so the reason why we choose to talk about colics is because it's a very common emergency and one of the most common emergencies in equine vet medicine. And as this USDA website reports the incidence of colics, you can see that the numbers are pretty high. Between 3.5 and 26 cases every 100 horses are at high risk. And with these, there is a potentially high cost involved with treating colics, and for sure a high emotional toll on all the owners for horses. And so we deeply care about colic events, and we really want to make sure that we do everything to try to avoid, when possible, our horse colicking. And then you can see here the distribution around ages of horses, and you can see that it's common in all age ranges, and then a little bit more when they get towards the adult and then older type of age range. And so when we talk about colic, technically colic means abdominal pain or pain, because we will see that not every cause of colic is actually abdominal, but in general, when we talk about a horse colicking, we mean that a horse is showing signs of abdominal pain. And the signs of abdominal pain can be shown very different amongst different horses. Some of the signs that we all can recognize is like in the picture here, horse is rolling, they can be sweating, they might be standing, agitated and pawing, they might be lip curling. This is also a more subtle sign of pain or discomfort that they might exhibit, or they might just be laying down and be specifically a little dull or lethargic. Like in this mare here, the foal is pawing, she's a lactating mare, the foal wants her to get up so he can nurse, and the mare just doesn't feel well, which is not usual. There are some breed changes as well in the way they exhibit pain. And so, for example, this is a draft breed, and they are notorious for being quite stoic. And so they might be less likely to be rolling in the field and sweating and be very, very agitated. They can do that, but it might be more subtle the way they exhibit colic signs versus maybe a young thoroughbred, like very likely in this case, where they are very concerned about what's happening. They are unexperienced, they are very scared, and so they potentially overreact a little, or they just show a little bit more what they are feeling. And so definitely some breed changes and some signalment changes in terms of the way they show colic signs, and being the younger horse, the more scared and concerned, and the older horse, the more stoic one. And so it's important for us to make sure that we recognize colic signs. And today we will go through a little bit more of the gastrointestinal tract, because as I said, a lot of the time it's an abdominal type of pain that relates to the gastrointestinal tract. And we'll go through from the start, the mouth and the esophagus, and then I added a few stops. We'll stop at the stomach, we'll stop at the small intestine, cecum, large colon, and small colon. As you can already see how long their GI tract is about 30 meters long in a 500-kilogram horse, so a normal size horse, and can hold a lot of feed and a lot of liters of liquid and water, about 180s. And so we have different parts of it. And the important thing is to recognize that it's very long and very complicated. And that's why it's also very prone to have some problems. And so if you imagine your horse standing in the field, munching on some hay or some grass, the journey of the hay definitely starts with the first stop at the mouth, right? So here, one of the things that we want to look at is the health of our teeth, because the teeth grind the food into very small pieces, and the ability of chewing and masticating appropriately is very important. Horses, unlike dogs and other species like us, cannot vomit, and so it's very important that whatever they swallow is broken down enough that it can go safely through the rest of the gastrointestinal tract. And so it's very, very important that they are able to have a good mastication and chewing activity. And so, as I said, good teeth will promote good chewing activity and therefore some healthy gut. And that's because once we have digested fibers in the mouth, they start their journey down the line, and they will reach the rest of the gastrointestinal tract where it can ferment appropriately. Instead, when we have some problems, and I listed these, some common horses' teeth issues, we can reduce the surface area for all the digestive enzymes to act on in the mouth, so the first stage of our digestion, and then have a slower, incomplete digestion. And we know that there was a beautiful seminar about horses' dental diseases. Horses' teeth continuously grow and they need to wear quite evenly. And so when we have abnormal sharp points, hooks that are untreated, changes in the mouth shapes or wave mouths, then that can make chewing quite painful and quite inefficient. And so that can definitely be a problem, as can be a problem like these pictures here. They show missing teeth or teeth that are very worn down. And so you can imagine how difficult it is to chew long fibers like hay with these missing and abnormal teeth surface. This is a picture of what's called here a diastema, and so abnormal space between teeth. That this is with feed packing, and when you release and clean the feed packing, you can see that there is a big ulcer. So you can imagine how painful this is and how inappropriately the food will be chewed because of that. And then long-term dental neglect can cause different issues. This is a picture of equine odontoclastic tooth reabsorption and hypercementosis that if you were on the previous seminar series, you have heard about, and is more and more common in our geriatric population. But also if you neglect dental care, then you can have tooth root abscesses or infection that can really discourage normal eating and drinking. And so that indirectly affects, as we said, the motility and hydration. The stop number 2 is after the bolus of food goes through the mouth, goes through the esophagus as well. And in the esophagus, the esophagus is this big long tube that connects the mouth to the stomach. And so it's quite a long tube, 1.2 to 1.5 meters, so 4 to 5 feet long, starts at the pharynx up here, and as I said, ends up in the stomach. And it's literally a conveyor belt that brings the food down, runs on the left side. And so if something gets stuck here, and we call it choke, an obstruction of the esophagus, you can see a food bolus or whatever gets stuck, you can potentially palpate it and see it on the left side. You can see here that I put a couple of pictures. One of the most consistent signs of esophageal obstruction is this feed coming from the nose, and you can see the green discoloration of it. One other potentiality is that you feel the bolus of food, especially in this funny case where he swallowed an entire apple, again, not properly chewing. And you can see the apple here represented on X-ray. This is your trachea to orient yourself, and this is the esophagus with the stuck apple in it. And so truly any dental problem that we have just listed that lead to poor chewing can definitely predispose them to have this problem in the esophagus. So these bolus of food that get stuck, but also any other feed issues. So dry pelleted feeds like dry beef pulp or very coarse hay without adequate water and moisture can also predispose them to have choke episodes. Eating behavior like competition at the feeders or inadequate chewing time is also a possible risk factors, or underlying health issues like esophageal stricture or previous chokes. And why do we care about choke? Because it can lead to important consequences. First of all, it can rupture the esophagus with time that the bolus gets, the obstruction remains in place. But also it can lead to aspiration. So you see how they are dropping food at the nostrils, and this can be aspirated at the level of the trachea and go down to the lungs. And so careful feeding management, as well as other management factors and dental care, is very important to prevent these consequences. We finally have reached the stomach. So our stop number 3 is when the food enters the stomach, and things get very interesting here. The stomach is actually relatively small, can hold about 2 to 4 gallons, which is about 8 to 10 liters of fluid. So it's relatively small compared to the size of the horse and the rest of the gastrointestinal tract. But it acts a little bit like a storage area. If you think that horses are meant to be constant grazer, and so to eat constantly, they are built to have constant secretion, meaning that this part of the stomach here, this more red part, is the glandular fundus, where all the glands are, and those are the glands that produce the acids. And so one part of the stomach is a constant producer of acid, and because they are meant to be constant grazer, they are constantly produce saliva as well. And so the acidity of the gastric juices that are produced in the stomach is counteracted by their constant saliva when they are exposed to eating or grazing constantly. When that doesn't happen, you can understand how the acid that is produced here might affect the mucosa and also slush above in this kind of dorsal part that is of a different color, where there are no glands, but this is an area that is supposed to be a little bit of a storage area. And the reason is that when they graze, they form this bowl of food that sits right there. or right here, and prevents slushing of the absorbs acids and also prevents the slushing on the above area. And so when that doesn't happen because the feeding schedule is different, you can see how now all these area, this margo is the change of the mucosa color and composition, and also can affect above. And so when we look at clinical signs for gastric ulcers, like obviously colic is a big one. Usually they show signs of mild to moderate discomfort, but there is individual variation for that. Usually they colic after they're eating, but again, this can change. These animals might show irritability, behavioral changes when ridden, changes in their appetite or what they want to eat. High performance animals might show poor performances, decreased stride length, and some less common clinical signs, but you might notice a change in the air cut quality or poor body condition in severe cases. And this is a list of risk factors, right? We talked about how they are supposed to be constant grazers. And so inadequate roughage intake, and so inadequate hay or grass intake, fasting can definitely affect the health of the stomach. And so any other disruption in normal feeding can definitely result in a breakdown of defense mechanisms that the stomach mucosa has against its own gastric acid production. Other causes, anything that causes stress, so strenuous exercise, transportation, horses that are normal or horses that are ongoing sickness or are in hospitals in a different environment. So stress can definitely predispose them to development of gastric ulcers. And then medications also, NSAIDs, so Banamine, which is a common medication that gets administered as a painkiller, or dexamethasone, corticosteroids, throughout several mechanisms can definitely impair their barrier properties of the mucosa and definitely predispose them to gastric ulcers. One other important risk factor to notice is the high grain diets, and that's because fermentation of soluble carbohydrates that are part of this high grain diet, as this picture notes here, are likely to also contribute to injury of that mucosa, so that layer of the stomach. So how do we diagnose, how do we know if our horses have ulcers? So gastroscopy is an important diagnostic tool that we have. And so gastroscopy involves sending a little thin fiber camera throughout the nasal passages and then down to the esophagus all the way into the stomach to visualize the lining of the stomach, the two different lining of the stomachs and the beginning of the small intestine. So this is your esophagus, you go in, the stomach is almost an L shape, and you go out this way, right? And so going around, you will have this type of image on a screen or this type of image on our big screen. It requires the horses to be off feed because we want the stomach as empty as possible to be able to visualize the majority of it. And then as you can see in this picture here, a lot of the time they are sedated. Most of the time they are sedated, but they are standing. So it's a procedure that your field vet can do in the field or can be done at referral institutions as well. And so these are just some images of gastric ulcers to give you an idea. We do have in the vet world a grading scales and that a grading system that helps us with consistency when we describe these lesions, these problems. And so we go from a grade 0 here, which is pretty much like a normal stomach. This is the mucosa with the glands that we were talking about, and this is the top part of the stomach. We call it squamous mucosa, which is the one that is more adapted to storage. And this like little line between them, it's actually, as a funny name, it's called margo plicatus, and that's where we see most of the ulcers. And so we really want to visualize that very well. Grade 1 are the least severe changes, and we can see how this is all yellow. The squamous mucosa is all yellow, so we call that hyperkeratosis. There is some inflammation, but not truly some ulcers. When we start going up with the grade, we start seeing some small ulcers here in a grade 2, some more extensive ulceration here with the grade 3. don't get full, this is all food that can be washed out quite easily. And then when we go to the most severe ones, these are all very deep, several ulcers. Some of them are bleeding. And so you can see them here, you can see them here, and you can see them here. And so this is a grading system again that helps us like knowing what we describe to each other. There is another part. This is all the same area of the stomach. Instead, if you look at the stomach up here, we are looking at this main area. When we go to the exit point, the pylorus, that's called glandular mucosa or glandular part of the stomach. And so we don't really grade this area. We more describe what's going on there. And on this slide, I have a picture down here, which is exactly the exit, the pylorus. From here, this hole here on, you will be in the small intestine. And you can see how ulcers can also be in this area. And the reason why I'm pointing it out is because depending on where it is, treatments can be different. And your vet might prescribe you one of these drugs or others, but omeprazole is an FDA-approved treatment for gastric ulcers that is very effective for ulcers in this area that we just had looked at. Instead, if ulcers are in more the pyloric area, on the glandular area, treatments might be a little different just because the cause of them is a little potentially different. And so we don't want to get to the point where we have gastric ulcers. And so some things that we can do to prevent them is trying to work with your vet to do good nutritional management. And so pasture, if possible. There are some conditions that don't make it possible for your horse to be turned out on pasture and on green grass all the time. Again, work with your vet to try to see if another type of strategy like free choice hay, always available hay in some different amounts is something that you can do, limit concentrates, and then a lot of the times we add vegetable oils for protective effect on the gastric mucosa. There are also some other pharmaceutical strategies that your vet might help you with. And so there is an FDA-approved preventive dose of the omeprazole, so the paste that we have looked at before, at a lower dose that you might discuss with your vet giving to your horse if you know that periods of stress, like being transported to shows or being in hospital, is something that might trigger gastric ulcers. And so again, working with your vet for prevention, it's very important since gastric ulcers are quite a common condition. If we go further in the intestine journey, we are finally in the small intestine. And you can see here, I put a picture of a human, so we can see the three parts of the small intestine. We start with the duodenum, which is right after the stomach, and then a lot of jejunum packed all in our bellies, and then ileum is the last part. And so similarly to humans, horses have a similar very similar small intestine. And so the feed also after the stomach enters the small intestine that is all packed up here. And the small intestine, what it does is absorbs proteins, fats, and simple carbohydrates. And it's this very, very long tube where this absorption takes place. And if you think about how long it is, it's actually very long. It's 60 to 70 feet. And so when I Googled how many meters, is about 23 meters. And so they compare it to two small school buses in a series. And so if you line it up in your small short horse compared to the school buses, you can imagine how long this is and how packed that needs to be in the abdomen to fit all completely in there. And so the food goes through quite quickly at the rate of about 1 foot per minute. So in few hours, has moved already from what we call the foregut, which is the stomach and the small intestine, already into the hindgut that we will see in a second. And throughout this journey, we said that there is digestion and absorption of the major nutrients, and there is also participation of the bile, just like in humans and other species, through bile ducts that secretes enzymes to help the breakdown also of vitamins, minerals, and the starches that are very important part of horses' nutrition. And so when we look at this picture, we understand, although this is misrepresented, we understand how the small intestine is actually much longer when we stretch it out compared to other large intestine parts that we will see later, like cecum, large colon, and small colon. So it's the longest part of our intestine. So as a big role, and the small intestine, we'll see what problems we can have here. So because it hangs in these like long, narrow loops and is attached by this very thin sheet of tissue, it makes it easier for it to flop around and potentially do what happens here, which is a little twist or get trapped somewhere because it's really loose in the abdomen. Think about it like a little garden hose that kinked or gets caught. And then what happens, the problem is that there are blood vessels that go and bring nutrients. And so if these get really tight, then we can have the cutoff of the blood supply. And this is what we call twists or strangulating lesions. And so horses that have that, and not very common, thankfully, but will present with a lot of what we call reflux, which means that horses, as I mentioned before, cannot vomit. So when we pass a tube in their nose and we go down to their stomach is full of fluid if they have something that is obstructing the small intestinal flow, and they will give your vet a lot of fluid. So we call that reflux. Here is a picture of how the small intestinal looks on ultrasound. So small intestine is a tube, but should not be this distended. And you can see multiple loops. And this is an abnormal appearance. They look like very rounded, very taut, and they really shouldn't look like this, especially if you look at their wall. In all of them, they are quite thick. And so that's not a good sign, and definitely not a sign of health or good motility. And so they can present like that when they have strangulating or obstructive lesions. One of the common strangulating lesions in older horses, for example, in their later teens or 20s, is a lipoma. And some of you might have heard of these. A lipoma is actually a ball of fat, is a benign, fatty, growing tumor. And there is this beautiful picture from this paper where it highlights how the lipoma becomes a problem, because the majority of the time itself, the lipoma is not the problem. The lipoma might grow suspended to this little row, the little stalk or pedunculus. And the problem becomes when the little stalk goes around the mesentery and traps the small intestine, cutting off, just like in the picture here, the blood supply. And that's when it becomes a strangulating problem. And so I just warn you, I'm about to put a picture with some real guts, so please don't look if you don't want to look. And so this is how it looks in surgery. So this is all small intestine. We said it's very long, it's tubular, shouldn't look this distended. It should be collapsed and moving very well. Instead, you can see how this is all quite inflamed. And then obviously we have a part that is black, that is this part here, and is devitalized. And this is your culprit, the lipoma that you cannot see it here, but the stalk is around this area. And so we don't know the exact cause of lipomas. As I said, as long as they are not strangulating, they're not a problem if they live in the abdominal cavity. They are thought to be related to age, genetics, and potentially metabolic disorders as well. And so when we get to a point where it's strangulating and cutting off the blood supply, we have a treatment, and thankfully we can resect that part of intestine and put together, we call it an anastomosis, put together two healthy pieces of intestine. But that, of course, requires surgical treatment. There are many other possibilities of what can affect your small intestine, but examples of lesions that instead might not require surgery because they are not cutting off the blood supply, might be lesions where you have some obstruction of the small intestine. Like in these cases, parasites. This is a a long worm, and it's called ascaris, can impact in the small intestine. That usually happens with our youngsters, and so weanlings or late weanlings, either because they get dewormed all of a sudden and they have a very high numbers of these parasites, or because they were never dewormed, they might have a lot of worms that die all at the same time and get stuck in the small intestine. And this is actually a worm that is visible on our ultrasound. And so that's one example of lesions of the small intestine in a specific age range. And because we talked about older horses with the lipoma, this is instead a possible problem of our young horses, as it is intussusception, which means that basically a part of the small intestine telescopes into another, and we have a beautiful scheme here to make us understand how that happens. And here is the actual lesion in real life. And the causes of these likely is either parasitism or rapid dietary changes or whatever drives an abnormal intestinal motility. And so these might require surgery, but might hopefully not require a resection depending on the case. And so these are just some example of what can happen to your small intestine. And just like I did for the small intestine, I'll give you some example of what can happen to the larger part, not the longer, but the larger part of your gastrointestinal tract. So we are now, after the small intestine, end up in cecum, which is the human's appendix, much more developed in horses, and then large colon. And so the bulk of the digestion happens in this area that we call hindgut. In fact, horses are hindgut fermenters. And here the feed remains for quite a long time, for 2 to 3 days, and is fermented by the local population of good bacteria that lives there, and then gets absorbed. And truly, this is an area where the horse takes a lot of energies, because these bacteria will ferment the food that arrives, that is already digested, and then will produce some volatile fatty acids that get absorbed and will give energy to the horses and calories. And so this happens if everything is healthy and the food is chewed appropriately and is already digested appropriately in the small intestine. If that is not the case, then abnormal fermentation might lead to the production, instead of volatile fatty acids, which are a good thing, of lactic acids or other negative products that might even kill the good bacteria that live here, and then start a little bit of a vicious cycle of abnormal motility or gas formation, and these can become all of a sudden gassy and can move around and can give colic problems. This picture will show you just how large part, not even all, but part of the colon of a horse is. This is in during surgery. And these pictures as well, this is your colon that has a lot of curves here. So left colon, right colon. And then your cecum, that instead of being as tubular as the colon, you can see it in this picture here from the right side, because the cecum sits mainly on the right side. It's quite big and quite triangular in shape, and so has a kind of blind end to it. And I put some more picture. These are beautiful pictures of the inside seen from the left flank of a horse. So if you look at your abdomen from the left, and gives you an idea of the dimension of all these different parts of the intestinal tract. So this is your colon, dorsal colon, so stays on top, and ventral colon. And you can see how the colon has a lot of curves, even here, tight curve, tight turns. And so you can imagine that if you have a lot of food going through, it can get stuck in one of these turns quite easily, potentially. And so this is a normal position of the colon. The colon is in there, and if it becomes gassy, or we fully don't know why, but is not completely packed or attached very well to the rest of the body cavity. And so it can kind of move around quite a bit, and we will see in a second that can cause problems. View from the right side, again, we still have a lot of colon. This is dorsal colon and this is ventral colon, so a big part of the colon on the right. And then we have this beautiful comma shape organ that is the cecum, that instead is a blind shape organ that is mainly occupying the majority of the right side of the horse. And so when we look at issues that can affect these segments, again, it's like the majority of the issues will be hopefully in the large colon, seems to be more affected than the cecum in terms of numbers and incidence. Impactions are quite common, and the reason is that I had just shown you how it has a lot of tight turns, and so one of them is the pelvic flexure. And if you have a tight turn and you have also a stricturing of the diameter, if you have dehydrated food or inappropriately chewed feed or any other change in your feed bulk quality, then it might impact there. So pelvic flexure impaction is one of the most common large colon problems, and thankfully it has for the majority, most of the cases, as a medical medical therapy is effective. And so that is something that you're as a vet see quite often. But as I said, the colon might get gassy and might kind of tour around the intestine, and so instead of being on the left side, now the left colon goes on the right or goes on the left in different places. We call that displacements. And so those can also be treated medically for the majority. Some of them might require surgery. And then something that definitely requires surgery, we talked about the twist before of the small colon. Twist of the large colon is called the volvulus, and so it's represented here, where the big colon basically twists around its own axis and occludes the vascular supply. And those are very painful colic, so they look like this very often, and they require surgery. Some other things that can impact it, not very much in where I practice in upstate New York, but if you are in California, in the Midwest, or in the South, sand impaction is something that you might have heard of. And those are two x-rays. And that's the way we often diagnose sand impactions, that show the ventral colon, so the bottom part of the colon, full of sand. So you can see how this bright area, this is all sand, and this is all sand. And so that is something else that can impact in the colon. And that might be something that, again, depending on the area where you have your horse or where you are, you might hear of or might have been exposed to. When we look at the cecum, remember the blind organ, impactions are thankfully more rare. And the reason is that if you can imagine, this is a comma shape organ. And so if it starts impacting food, the outlet is up here. And so we don't see it until it's almost full. And when it's almost full, unfortunately, a lot of the time, these cases need to go to surgery if we catch them in time before they rupture. So cecal impaction is thankfully way more rare than large colon impactions and can have some more important consequences. Cecum can also build up some gas if dysmotile, can have some intussusception of the ileum. And so there are a lot more things that rarely can happen to your cecum. And so we mentioned how the colon can kind of migrate around, and I just wanted to give you an idea because it's quite fascinating how much in there things can happen and how much this big organ that is the colon can move around and get stuck in some not good position. So one of them is your left colon right here, that this is a normal position. And so what happens is that sometimes this decides, this is the pelvic flexure that we talked about, decides to move around and go on top of the spleen, all the way to really on top of the spleen, between the spleen and the kidney. That's called nephrosplenic entrapment. And you now see that your colon is stuck here. So this area can become quite gas distended. You might have some ingesta or food that gets stuck here. For a lot of the time, we can fix them medically. Some of them might require surgery. There are different ways of doing surgery. One of them, depending on the candidate and the amount of distension. So candidate selection is very important when you look at medical conservative management versus surgery and which type of surgery. But I wanted to put this here. This is a standing surgery, and I just want to show you the images of this part of the GI that is in between the spleen that is under here, covered by a layer of what we call mesentery, which is a tissue that brings vascular supply to the intestine, and then the nephrosplenic ligament. And so truly, it should look like that. It should be empty. And this is us after we got the intestine out of there that are closing this space, so this cannot happen. This is one of the preventive things that we can do to make recurrent nephrosplenic entrapment not happen again. So I just want to mention parasites. Again, you have had, there was a seminar series about it, so I'm not gonna be talking about this a lot, but remember them as cause of colic, and always work with your vet in preventing these. So perform fecal flotation and targeted deworming program, because there are a lot of different parasites that can cause a lot of different issues in the large colon as well. So we're almost at the end of our road. And so we talked about the large colon, but we haven't talked about what's called the small colon or descending colon. And the descending colon is this part here, 10 to 12 feet long, is a free floating muscular tube that, again, is the last part before the rectum. So your feed goes through it again. And these are some things that you might find as problems, right? And again, your poor dentition, poor quality hay, or lack of water, parasite damage, lack of exercise are all risk factors that can predispose you to development of impactions everywhere. And the small colon is definitely part of that. And so when you have impactions of the small colon is technically something, is technically where the fecal balls are formed. And so when the fecal bolus gets there, then it gets like, it gets divided and shaped into little balls, and that's what we see coming out. And that's the role of the small colon. So when they get impacted, instead of being balls, the small colon becomes a large tube, very enlarged with feed material. But impactions are not the only, are quite rare, less common than the large colon, thankfully. It's not the only thing that can happen to the small colon. We also can have some masses that get formed mainly in the large colon, that get passed and get stuck in the small colon. One of them is a fecalith. So fecaliths are hard stone-like masses of dry, compacted feces, and that can get stuck. They can get big enough, they can get stuck in the small colon and create obstruction. And then we have also these masses that can be formed by hair ingested, so we call them trichobezoars, or plant material, and we call them phytobezoars. So we have all these funny names for all these balls that can get stuck in the small colon. And then we have enteroliths that are more like a hard, and this is small colon here, and this is like fecal material abnormal. There is likely a linear foreign body in here, but here, because you go from a large lumen GI structure to a smaller bore, a smaller diameter GI structure, if you have foreign bodies, this is where they can get stuck. And so I was talking about enteroliths that are more like these hard mineralized stones that are often composed by magnesium ammonium sulfate or struvite, which are some minerals. And they look like these. You can X-ray and they look like that. They typically form in the large colon, and then they pass into the small colon and might get stuck. This is a picture of the small colon with an enterolith in surgery. And this is how it looks like when we remove them. Older horses, American mini horses, ponies are all at increased risk of developing these in several studies. And so at the end of the trip, it's a complicated trip with a lot of possible areas where things can happen. This is just what we call a colic tree of a lot of possibilities of what can go wrong. mine was just a presentation about some examples, but the point of, your vet coming to your farm to look at your colicky horse is try to find out what is happening and where, and so we can establish the best way to fix it and go back to our normal life. And so when we talk about the colic workup, it's a term that you might hear from your vet and might concern a lot of owners and horses. I just want to go through a little bit of what that means and what your vet might be doing some of these procedures or all of these procedures, depending on the case, and see why he or they do these procedures and why they're important. And so nasogastric intubation is one of them, and I believe at least some of you have seen it perform on their horses. And so why we do it? This is a very important procedure that can be life-saving, and it's meant to release stomach distension or assess for stomach distension. And as we talked about, horses cannot vomit, and so we have to release the distension if we don't want that the fluid that accumulates might rupture the stomach. And the fluid might accumulate from a small intestinal lesion, being it strangulating or not, that is backing up the fluid into the stomach and then stays there because we cannot vomit. But the second purpose is also your vet might give some oral fluids in a horse that is dehydrated, especially in pelvic flexure impactions. Oral, or we call it enteral fluids, are a really valuable treatment that your vet might be doing. And so this is what we do. We pass a tube in the nasal passages, and then with good restraint or potentially sedation as well. And then we make sure that the tube goes from the nose into the esophagus that we have talked about. We talked about how the esophagus is mainly on the left, so sometimes we can see the tube going in, we can feel the tube going in. So we have different ways to check to make sure that we are in the right place, because the wrong place where we could be is in the horse's lung, which we don't want to go. So we'll check the positioning, and then we'll go all the way to the stomach. And again, either we release distension, getting some fluids out, or we can administer something based on the horse's condition. And so that's one of the very important things that you might be seeing during your colic workup from your vet or at the clinic. Another one is the rectal exam, and you can see how some of us are really excited to perform rectal exams, but the rectal exam is actually very important, and we are very lucky in large animals that we have this way of assessing what's going on inside the abdomen by directly palpating what's going on. And so aids a lot in making a diagnosis and what's going on. So whomever performs it needs to be comfortable with assessing what's normal versus what's abnormal, right? So we can feel, as you can see in these beautiful images down here, that we can feel just a part of the entire content of the intestine or the abdominal cavity. And so this hand is palpating the cecum. You see some small colon here. You can see kidney and spleen on the left, and we can palpate part of all of that. And so this is very important to assess, is there an impaction in any of these palpable structures? Sometimes you can feel it. You can feel if the intestine is very distended. Is the small intestine very turgid and distended? Is there a lot of gas? In some of the worst cases, you feel a lot of gas, so much that your hand cannot go through the rectum because the gas is backing up to you. And so very often is part of your colic workup, and you will see that your vet will likely sedate the horse and give some drugs to relax the rectum, and then ask you to hold it safely or possibly put it in stocks, because it's not a risk-free procedure and needs to be performed as safely as possible. Abdominal ultrasound, so looking at the different parts of the GI tract with an ultrasound can be very valuable, helps narrowing down where the problem is and which part of the GI tract that we just have looked at. The is affected by the problem. And so can be really important. This might be something that your vet is able to do in the field, is often performed also in a hospital setting when your colic gets referred. But as I said, there are a lot of portable ultrasound that your vet might have available too. And then something that, again, might be performed in the field, might not, depending on individual comfort, but also depending on cooperation of the horse and facility requirement, is what we call abdominocentesis, or more friendly name is belly tap. So basically, we sample a little fluid in the abdominal cavities called peritoneal fluid, and we look at different parameters on this abdominal fluid. And so you can see how we put a little needle in a sterile fashion and we obtain some fluid. And on that fluid, what we see is we look at the color, so the physical property, how much we get, and then we look at other parameters. And what we are trying to assess is that if there is compromise of the intestine. And so we're trying to assess if there is a strangulating lesion, a lesion that requires surgery versus a lesion that does not require surgery because there is no devitalized intestine in the abdomen, or at least as best as we can tell, there doesn't seem to be. So we kind of put together a lot of information to help us guide the next step of treatment. And then, of course, in cases where your horse might have colic and fever, we might have a high white count with some bacteria and might be able to diagnose some inflammatory diseases like peritonitis. And so really valuable test that in a hospital setting gets performed quite often. And so I said, we are deciding if what is the best management, right? Is conservative management, is it surgical management? And based on severity, based on if we find the evidence of the vitalized intestine, or if depending on what our togetherness of information that we gather from the colic workup, we might decide that conservative medical management is appropriate versus surgical management. And I would say medical management is the most common, especially because the most common type of colics are mild colics that can be managed in the field. And the degree of medical management, you can see a series of pictures that go from injecting some Banamine, so some painkillers. Epsom salt is something orally that your vet can give through a nasogastric tube, or IV fluid. So the degree depends on the severity of what is going on and potentially if the first line treatment has been successful or not. And so here is a list of things that we can do for and what we call medical management. And then again, depending on the severity, it can be quite straightforward or might be quite intense, requiring a lot of monitoring and a lot of care. And those are usually cases that are taken care of in hospital settings, which is not the majority of colics. Instead, some lesions require surgery, either because they are what we call twists, so strangulating lesion, or because they don't respond to initial medical management. And of course, surgery is quite more of an intense procedure. We have to put the horse under general anesthesia, so it will be on his back on the table for the majority. And then we require a team of expert technicians, expert surgeons that whose goal is to identify the lesion and fix it. And so after you fix the lesion in surgery, then, and you can see how big the surgical field is for a horse compared to small animal or compared to humans. And then after recovery from anesthesia, there is a period of post-op rehabilitation, and then hopefully going back to a normal life for your horse, truly depending on the lesion that is ongoing. Colic means pain, and sometimes we talked a lot about gastrointestinal pain or gastrointestinal causes of colics, but don't forget that there are other causes that might not be gastrointestinal related and can, because colic is such a specific term, there is a list here of things that might be going on, some inflammatory GI related like colitis with or without diarrhea. People in this area might be aware of Potomac horse fever as an infectious cause of colitis and potentially diarrhea. And there are other causes of disease that can cause GI disease that can cause colic, and a lot of other causes of non-GI, so non-gastrointestinal related, that cause pain. And so horses might show pain the same way they colic because that's how they show pain. And so there is a long list of diseases that are not gastrointestinal but present with clinical signs of colics. And so you might wonder, what do I do when I have a horse colicking? And so always call a vet. Try to remove all the feed. You can keep the water available. If you are able to count a heart rate because you have been trained or your vet can tell you how, check the vital signs, color of the mucous membrane, lifting the top lip is important to make sure they're moist and they're pink. You can check the respiratory rate. Is it breathing really hard? Are the nostrils flaring? And as I said, if you know how to do it, you can also check the heart rate. Walk the horse sometimes helps relieving some mild discomfort. Do it only if it's safe, and try to just walk them to take the mind off what's happening and to make them a little bit more comfortable, but try not to exhaust them. And then don't give any drugs unless your vet is the one advising it, because they can definitely mask pain signs. And if you give a drug and your vet doesn't know about it, when the vet gets to the farm, things might have changed and it might be more difficult to interpret clinical signs. And then I hope I convince you that early recognition and prevention are potentially life-saving. And so what you can do today is talking to your vet about good dental care, deworming plans, and then your feeding schedule, your turnout schedule, your management at home, and try to discuss also how to deal with stressors in their routine, so travel, competition, or things that might change their routine, so how to manage that, and then always monitor appetite, fecal output as closely as possible, because in this journey you are the driver. And so again, the key takeaway hopefully is that early recognition of what colic is and what might be going on is key to resolution. And so hopefully we can go from this sad horse to this happy horse very quickly. And to put together all these images, I had to kind of fish in a lot of resources. So this is my bibliography. There is a lot published. There is a lot online in the scientific literature that is available for you guys too. And I thank you all for your attention. It does seem true that colics happen especially on nights and especially on weekends. And we don't know why, but that seems to be the way it happens. And I'm happy to take any questions.
Thanks, Dr. Delvescovo. We've got a couple of questions from the audience that we saved for you. One of our participants is asking if you think that there are areas where you see mesenteric torsions happen more commonly, or other situations where they may happen more commonly.
Geographical areas?
Yes.
Okay, I don't know that answer. I would say it's not a common cause of surgical lesions, so it's not something that we see very often. And at least in this area, thankfully, we probably see one every couple of years. And so I'm not sure if that's more common in other areas. Thankfully, it's not a common cause of surgical lesions.
One of our other participants is asking if there are any risks associated with managing an impaction colic with oral fluids, and whether those oral fluids should include electrolytes.
So enteral fluids or oral fluids are one of the most effective way to manage especially large colon impaction, so the pelvic flexure impaction, the most common one. So I would say that's usually what we start with together with some painkillers. And because they need a large volume, normally they have an nasogastric tube in, and so the volumes, right, you are giving a lot of liters every few hours. And so all the complication with maintaining a nasogastric tube in place, making sure it's in place and it goes right into from the esophagus to the stomach and doesn't come out is very important when you're managing them on the farm, because the risk is to put all those liters in the lungs instead. And then a lot of horses might tolerate a large amount of liters, and basically the fluid will go through and moisten the impacted food within the lumen of the intestinal tract and will be fine. Some horses instead, because the impaction is taut, might not tolerate that, which means that the fluids are going to come back through the tube. And so those horses might get uncomfortable and might require a more targeted management of fluid, when to give and how to give. Electrolytes or isotonic fluid are usually fluids of choice. You have to be careful with electrolytes balance solutions. So you have to be careful that you have a balanced amount of electrolytes and not to give what we call hypertonic solutions that are very osmotic and can draw a lot into the intestinal tract, which is good if given in the right amount. If given only the only type of fluid that you give to the horse, then your hydration can be compromised. And so a lot of the time depends a little bit on the response after the first few times you do oral fluids. And again, this is where it becomes very important to work with your vet about which type of fluids, how much, and is this something that you can do on the farm? Because a lot of the time, yes, the answer is you can do it on the farm safely.
Great. I think this one's a bit of an age-old question. Do you let horses roll or do you let them walk?
So if I let them roll or walk?
Yeah, so should owners, if they have a colicky horse, should they let their horse continue to roll, or should you recommend that they walk their horse?
Yeah, I think you have to be safe first. And so if you are trying to get the horse up and you're trying to walk them, but they keep going down and they keep to roll, and it becomes dangerous because they might roll in the middle of the breezeway, in the middle of your riding arena, then you might want to put them in a stall where they are a little bit more enclosed and it's safe for everybody, personnel and horse included, to let them roll there. I would say if you can walk them, and a lot of the time just getting the lead rope on and walking them outside, if the colic is mild to moderate, they might be discouraged from rolling. And so I would do that if that's the case. But if that is not the case, then I would make sure that you and the horse are safe.
Thank you. The next question is about supplements. Are there any supplements that have some evidence to suggest that they are beneficial in preventing colic? And this question is specifically in reference to improving the microbiota of the gut.
Yeah, challenging question, I would say. I think the majority of the supplements have very little evidence that they are a game changer. However, because we still don't know a lot about the microbiota, it's really tough with the supplements to target a replacement if we don't know what we are replacing, if that makes sense, right? And so there is a lot of ongoing research that is advancing the field, and I think is going to be really important for colic prevention. I think a lot of the supplements out there have some mild to moderate evidence. I'm not sure I could recommend one that works great miracles over others. But again, people have different experiences. So your vet might recommend some supplements because they have worked for them. And so working with your vet, geographical area, feeding types might also affect the microbiota. And so I think it's important to try to work with your vet on that.
Okay, and I think the last question we'll answer live. Dr. Delvescovo, can you just sort of elaborate a little bit more on the difference in success between surgery of the large colon versus the small intestine?
Yeah, it's kind of a general question. So it really depends what the lesion is. And so I would say that they can be both successful. It really depends what you are facing. So if it's a strangulating lesion, I would say the vast majority of the strangulating lesion we see here is small intestine. And so I can comment more on that. Both of them, both small intestine and large intestine, have options for resection. And so resection means when you take the devitalized part out. And so I think the key to both of them is early recognition and early treatment. And so this is when it's important to act fast, even if the colic is mild to moderate, and you might want to wait to be proactive in those cases as well, because in either cases, a strangulating lesion recognized earlier will be the key for success, no matter if that's a small intestine versus a large colon strangulating lesion. As I said, depends on the lesion, depends on the condition on the intestine, so on the viability. Both areas will have several options for resection, and so a lot of options are available if needed. But what you are hoping in either cases is that you don't get to a resection because you have caught it so early that you can leave all the intestine in there.
All right, everyone. I think we're going to wrap it up there. Thank you to everyone that joined in with us. We've had a really great attendance tonight. Just another reminder, our next seminar will be October 21st with Dr. Goodale here at 6 p.m. and as usual. So thanks, Dr. Delvescovo. I really enjoyed your talk.
Thank you so much. Bye, everyone.
Thank you.